That's the bullseye, typical bullseye macular that you see on the fundus, and that's the fundus autofluorescence. So the central area of hypoautofluorescence that you see is an area where there is a complete RP atrophy, and that area that's lit up, the hyperautofluorescent area, is where they are lipofuscin-laden RP cells, and therefore those are the degenerating cells. And that's the OCT, which shows that there is a complete loss of the iris layer from that point to that. So that's the other eye which has similar findings, and he's the only child of non-consanguineous parents, and that's VRG. So if you look at it from what we discussed all this while, so that's a normal dark adapted ERG. So initially they used to be called the SCOT, and that's the oscillative potential. So the photopic and the flicker. So the nomenclature has changed a bit, but the function is clearly the same. So his ERG is normal in both the eyes. So does this mean he has no retinal dystrophy? No, like what we've been discussing, it only means that whatever the problem that he has is not affecting the entire retina. So it is restricted to the macula. So if we had done a pattern ERG or a multifocal ERG on this patient, it would have definitely shown abnormality. So this patient has Stargardt, and a genetic analysis indeed confirmed that he's compound heterozygous for 2 mutations. So this is something called group 1 Stargardt. So I just want to show you that Stargardt, based on electrophysiology, we divide into 3 groups. In group 1, you have a completely normal full field ERG. In group 2, you have a cone dysfunction, whereas the rods is generally a normal. In group 3, you have both the rods and the cones being abnormal. So that's group 2 disease. Let's look at this. This is a 12-year-old girl, very bright girl, who in fact wants to pursue medicine. And her main problem is she's unable to read the letters in the classroom for some time. Vision of 660 N12 and 638 N12, and that's her fundus. So you have those classic, the beaten bronze appearance that we talk about. And look at the autofluorescence. So there is a large area of hypoautofluorescence. So her macula is really not functioning very well, and that shows the loss of photoreceptors on the OCT, and that's in both the eyes. So she is the first child of consanguineous parents, and that's her ERG. So, alright, so in fact this is what the ICIF recommends, that you always show both the eyes and the comparative normative control for your lab. So this is what in fact Dr. Ashwin showed in one of the graphs, that what we now started doing is to have the normative in all the patients and show the patient's response in black. So it's helpful. So if you look at it, that's the scotopic ERG, that's nearly normal, and that's a near normal combined response. And look at the photopic ERG. So that's the control, that's the normal photopic ERG. There's a definite reduction in the photopic ERG, and so is the flicker. So this girl has a group 2 Stargardt disease, and indeed we could confirm that with she's got a severe homozygous mutation and in the family. So this is a 22-year-old plumber who's had difficulties with night vision, not just difficulties with distant vision, but it's also got difficulties with night vision. And his vision is about 660 N18 and 645 N18, and that's his fundus. So this is the classic fundus flavimaculatus that we described earlier, although the original description was only of those people who had the peripheral flex with no macular involvement. So that's the beaten bronze appearance and the multiple flecks that we see. And the FAF confirms that significantly. This is one thing that I want to emphasize, that fundus autofluorescence is extremely helpful in patients with dystrophies. So that's the hypoautofluorescent RP atrophy, that's the lipofuscin-laden hyperautofluorescent area, and all those flecks that are either hyper or hypoautofluorescent, and the loss of the ISO is there. That's the other eye, similar looking, only son of non-consanguineous parents, and that's the ERG. So it did show that both the rod and the cones are definitely subnormal. So this is something that we would group as a group 3 Stargardt, because both the rods and the cones are involved. In fact, he did show a homozygous mutation for ABCA4. So Louis et al. Did classify them as, like I said, group 1, 2 and 3. It is not necessary that one has to go on to the other. or so, but because there are patients who can just remain at group 1 for their entire life. And so it is not, the phenotype-genotype correlation is not very strong in these patients. So you can't look at a fundus and say, oh, this is group 3 Stargardt. So it's based on the ERG. This is a very interesting child, a 4-year-old child. The father is CEO of a major research lab in India and the US. So the main complaint is that the father had was the child is holding the iPad too close to his eyes, and otherwise a completely normal child. And so otherwise normal birth history, vision of 624, 660. And so those are non-consanguineous parents. They have an older child who is normal. And look at the fundus. The fundus really does not look great. So a lot of pigmented alteration of the fovea and an extensive, not so great looking retina throughout in both the eyes. So you also see that the photoreceptors are completely lost on the OCT, and the ERG, as we expected, was near completely flat. So there is some amount of waveform remaining, but it is a near completely flat ERG. So this child has a form of Leber's congenital amaurosis. And in fact, we did sequence this child, and this child has a RDH12 mutation. The point that I want to make is, so what we did was to go ahead and refract this child, and following refracting this child's vision is 615, 618. Sometimes when you look at a fundus like that, it is hard to understand that the child may actually be doing this well. So it's really important that you do an appropriate refraction and do an aggressive amblyopia management if it's required, because this child would not have had those, if we looked at the fundus and said, oh, he's not going to see much, we would have done the aggressive amblyopia management, but he is doing pretty well with the glasses. So it's important that an appropriate refraction amblyopia management are done in children who require them. This is an interesting guy, a 25-year-old gentleman who came with acquired night blindness. He says he was fine all the while. He's night blind for 1 month. There is no family history, of course, consanguineous parents, vision of 6, 6 and 6, and completely normal looking fundus. So at this point, you have to step back and say, if there's an acquired night blindness and the fundus is normal, so what are we looking at? That's the normal autofluorescence, and look at that really neat photoreceptor layer on the OCT. The patient did appear malnourished, and when he asked, he said he'd had some kind of intestinal surgery some time ago, and we did the ERG. So look at that. There is no rod function on that. A minimal there, yes, and a little less cone than what you would expect, but the flicker is near normal. So that's in both the eyes. So this is a gentleman with almost an isolated rod dysfunction, acquired night blindness, and has had intestinal surgery. So clearly we're looking at probably a vitamin A deficiency. And of course, he didn't have the classic bite out spots or conjunctival xerosis. So when we went back and I spoke to his primary physician, he said he had been diagnosed with Crohn's or abdominal cocks some time ago, treated with ADT, and the full thickness intestinal biopsy had shown a lipofuscin of the intestine. Apparently a very rare condition. There are about 2 or 3 case reports in the world. And so his vitamin A levels were really non-existent. So it was 0.02 compared to what that's normal. We went ahead and administered vitamin A, and lo and behold, so the ERGs came back to normal. So it's essential that we keep these things in mind when we are looking at someone with a history of night blindness. That was an acquired night blindness. This is a 15-year-old boy. Basic difficulty is that he's had difficulties with dark adaptation since early childhood. There is a family history of similar complaints, mainly in the men in the family. So that's the proband and 2 others affected. Vision of 618, and that's a fundus. So you need to carefully note that the macula does not look normal. The rest of the fundus is normal. There is nothing else in the periphery, and the autofluorescence is mildly abnormal. Let's skip that. Okay, so that's the OCT. Look at the characteristic sciatus cavities on the OCT. I think OCT definitely has changed the way we look at retinas and practice retina. So we did an ERG, and so that's the rod scotopic response. That's near normal. And look at that. Look at the darker, the combined response. So there is a mild reduction there, and look at that. So you have the B wave. So a normal B wave should look like that. I'm sorry, it's not the same controls, but anyway. So that's the normal B wave, and look at that. So typically you should have a much larger B wave in the A wave. So you definitely have a much smaller B wave. So this is the classic negative ERG that you would see. And his cone function is normal. So this is a male patient with 618, excellent inheritance, 4-wheel chassis. So we're looking at the possibility of either eccentric or CSNB. So possibly a CSNB, excellent retinal in this patient. We've gone through, Dr. Jalali has taken us through this. Not every retinitis pigmentosa has to look classical with the pigments and so on. That's something we need to know. A 26-year-old gentleman, father is a big builder in Bangalore, difficulty in dark adaptation for quite some time. That's the consanguineous parents with the only son being affected. And his vision is 660 and 60 in both the eyes. That's his fundus. So he had initially been referred to me with a diagnosis of disc edema. But if you look at that, if you especially look at these peripheral arterioles, you see that there is, I'm sorry I don't have autofilms that look much better, but there is something called a relative sparing of those arterioles, and that peripheral coats-like response. A lot of a specific mutation called CRB1 mutation can have this significant vascular changes that are associated with rod cone dysfunction. That's the other eye. And so the disc edema was mainly because he had this huge drusen. And if you look at this, that's a very thick retina compared to the normal. So this is another feature of CRB1 mutation that we look at. That's in both the eyes. So he had a very extinguished rod and cone system. So he had definitely a severe rod cone dysfunction. So he did have a CRB1 mutation. I don't have the details of the genetic analysis, but he had a CRB1 mutation. Again, talk about, I think this is something Dr. Ashwin and Dr. Jalali have already touched upon. A 15-year-old gentleman with photophobia, a 15-year-old boy with photophobia, clearly subnormal vision and a complete loss of color vision. The not much refractive error, and the fundus is normal. So it's essential not to label these children as malingerers, because it's often easy to say that, oh, the fundus is normal. I think, he's malingering. Because especially from the poorer background, if you see children who don't want to go to school and so on, it's easy for us to say that this child is malingering. So that's the completely normal rod response and a completely flat cone response. So this is the rod monochromatism or the achromatopsia that we were talking about. So again, not everything with dots in the eye has to be abnormal or a dystrophy. So this gentleman, a 40-year-old IT professional, I think, I can't remember, I've seen him a couple of years ago, had been told that he's got a progressive retinal dystrophy and therefore he may go blind. This is one thing, although not really relevant, I'm just going to say this, that not every patient with retinal dystrophy is going to go blind in his or her lifetime. Because this is something that I often hear patients being told that, oh, you have retinal pigmentosa, so you're going to go blind. So this gentleman had made plans to change his profession because he was under the impression I'm going to go blind in a few years, so I have to make sure that, I'm okay by that time. So that's his autofluorescence. Look at those extensive white spots and the normal ERG, a completely normal ERG. So this patient had what we call a benign fleck retina, which is just a benign variant and has no retinal dystrophy. This is I think a 6-year-old child. Okay, so we've spoken about a 6-year-old child with difficulties in dark vision. I think the fundus pictures are quite characteristic. You see the classical Mizuho Nakamura phenomenon. So that's before and after dark adaptation, and you see the ERG. So again, a classic electronegative ERG on the combined response. So it's in the combined response that you typically find this electronegativity. So you've got to look for those in the combined response. So Dr. Ashwin is right that I see the fundus and then send for an ERG. So he's, unless I give him the details, so I play with him. I hold on to the details sometimes and say, okay, give me the diagnosis and let's see what you say. So this is a 14-year-old child with difficulty in night vision. Okay, so this is, so this child basically has night vision difficulties, and it's something Ashwin has already shown. I want to bring this to you because look at those characteristic nummular pigments all around. So let me show this further. So that's what it is. So you have these characteristic changes in a patient with enhanced Escone syndrome. You see these nummular changes all around. You are looking at a patient without a doubt at enhanced Escone syndrome. And it is also very common for this. So there's an autofluorescence that lights up so well on a FAF. And so it is very common for these patients to have a lot of CME. It's extremely common. And they don't respond very well to the routine agents that we see. So the sister and mother normal, and look at that. So that's, you definitely have a dysfunction there. This is what we were talking about. So if you have these two that are similar looking, the dark adapted and the light adapted 3O ERG, you are probably looking at an enhanced Escone. So we confirm that with a Escone ERG. That's the last case, I think. Yeah, that's courtesy Dr. Robs again. This gentleman presented to neurologist in 2009 with central scotomas and vision of 612, 69. Normal color, normal Amsler. That's his fundus. I don't think you can make out, but there is a little yellowish dot right at the center of the fovea, otherwise completely normal fundus. Again, you see that a little more pronounced on the FAF. So see that. So that little cystic lesion of the outer retinal layers at the fovea and normal ERG. So those are the dark responses, the bright responses, the pattern ERG, and the rest of them. So he came back a year later saying he's had a further drop in vision. His vision was 612 now, and that yellow dot is a little more pronounced. Same on that. So I don't know if we see these kind of patients here. Now this is something called Popper's retinopathy. So this gentleman gave a history of using amyl nitrate inhalation. Now this amyl nitrate is a recreational drug that's, in fact at one point I think it was legal in the UK. I don't think it is any longer, but so amyl nitrate inhalation is quite common there. So this gentleman did confess that he was using amyl nitrate for a long time, and so those patients typically present with loss of central vision and that central yellow spot. The full field ERGs are typically normal. This was first, in fact, reported by Isabel in France in a patient who had presented with amyl nitrate inhalation. And look at that. So that does get better and becomes normal. So I haven't seen a case, but I thought that was extremely interesting. Thank you so much. So if anybody do have any questions, and I think all of us are ready to take the questions. Thank you.